who's doing the first talk. I'm sure most of you heard him speaking in the plenary session. I wanted to introduce him specifically because we were talking about mentorship, and I've identified Bruce as my mentor, and I appreciate everything that he's done for me. He was also my co-supervisor for my doctoral. So, yeah, really appreciate everything you're doing for us as a country and as a continent. So looking forward to your talk, Bruce. Thanks.
Thanks for your kind words, Ada. Morning, everyone. I've got 4 talks today. So some of the slides you might see in different talks, and at the beginning I do need to remind people about APOG, because really the work I present is the work that large number of the people at this Congress have actually done the work. I've been asked to just talk about the African outcome studies and what they mean for research. So these are all investigator-initiated and led projects. I think we need to understand the research findings of the work that's been done by APOG if we want to know what we need for future research to improve perioperative outcomes. So, as I said earlier, APOG it's a big group. It's got 42 countries, or representation from 42 countries, over 1,100 hospitals, and probably about 2,000 investigators. The work that's has been impressive in adults, children, maternal outcomes, COVID, and now critical illness. And the critical illness ACUS was led by Tim Baker, who's sitting in the audience over there. So what does APOG taught us about surgery in Africa? I think it's taught us about these things: the geospatial access, the workforce, the volume and types of surgeries that are happening, the complications, failure to rescue, and mortality. So in ASOS, we knew that for every hospital, it served a median population of about 800,000 people. And when you looked at the workforce, there was less than 1 clinician specialist per 100,000 patients. That is an obstetrician, surgeon, or anesthetist. So a very tough working environment. And then if you look at the volume of surgery done, in Africa, we're doing about 600 cases per 100,000 patients. The target for the Lancet Commission is about 5,000. The reality is in the high-income countries, they're delivering about 8,500 cases. But to get to 5,000, we need to do 8 times more surgery than we're currently doing in Africa. So if you break the surgeries up, it's very interesting, because the most common surgery we do is a cesarean section. 1/3 of all surgeries in Africa are Caesars. Having said that, we should still be providing 2 to 3 times more Caesars to provide a sufficient number of Caesars to decrease maternal mortality. Then you start to look at the other surgeries, like cancer. We need 4 times more surgery for cancer. And then what is known as other surgeries, these are the subspecialties: neurosurgery, vascular surgery, cardiothoracics, ENT. I would call them the neglected surgeries. They're virtually non-existent in Africa. We do know now what complications lead to death. That's failure to rescue. And we can focus on the ones which have a high population attributable risk. So this is where we could maybe potentially make a big difference. So in adults, the population attributable risk is mostly around bloodstream infections. I think Caroline Simons is here. Caroline Simons is leading this sub-study, and this has still got a way to go, but hopefully it'll be published in due course. And we know from ASOS and the maternal mortality paper that about half of all mothers die following hemorrhage. And these complications lead to failure to rescue. Mothers, at least adults, failure to rescue is twice the global average. Mothers 17 times higher and kids 4 times higher. And this leads to these terrible outcomes that we know so well now. Again, at the end, you see the adult critically ill patients. So this is from the ACIOS work, which has just been submitted. But basically, critically ill patients in the hospital, their mortality at 7 days is equivalent to that at 30 days in a high-income country. So what can we do better? Certainly we can improve the quality of care. So there's a signal that in the studies when you look at ASOS in adults and ASOS peds, that only about 50% of the cases actually have a surgical checklist. And when we put our data together with data from USOS and ISOS and the Global Search Group, that you see according to the HDI of the country, as the HDI goes down, the use of surgical checklist falls off. And the scary thing is, when you see it's emergency surgery, there's even less use of the surgical checklist. So we know the complications that lead to death, and we know that there's failure to rescue. But the reality is, it's very difficult to implement these changes in practice. And so I think, going forward, I came originally from a trial background where it's very simple. You do a simple intervention, like give a drug, and then see if it works or not. But the reality is, to improve the quality of care in Africa, we need complex interventions, which means we need to develop ways of ensuring that we can implement these changes, and we can track the processes for implementation. So as I showed you earlier in the previous talk, that this is how I see improving quality of care within a health system. If you scan that QR code, you can download the book onto Kobo. But basically, working from a team inside a hospital or in a ward, and then building out from that, the knowledge of the team, and that a deliverable intervention, tracking how it's implemented, and then ensuring you've got the resources to do everything. We also need to look at health system strengthening. So there are lots of signals in the work from the Apple group which shows how weak our health systems are. So in ASOS Peds, we asked a simple question. We just asked the surgeons if the operating theatre was safe for surgery, and we asked the anesthetists the same question, was the operating theatre safe for surgery? And this is what it looks like. For neonates, only half of the anesthetists and surgeons think the operating room is safe to do the case, even though they're doing neonates. And infants, 65%. And only once you get, into the older children do we start to get 80 to 90% of anesthetists and surgeons feel the environment they're working in is safe. What we also saw in the adult study in ASOS, that when we looked at provision of sedation and looked between physicians who were providing sedation and non-physicians who were providing sedation, that there was this massive difference in outcomes. So for severe complications and death, it was about 10 times higher if it was provided by a non-physician. And so we're very fortunate to work with the ANA on this paper, because they taught us a lot about statistics, and every way we tried to control for the difference between the physicians and non-physicians, we couldn't quite match them. And the take-home message was the environment. The non-physicians who are forced to provide sedation for surgery are doing it because they're in an environment where they cannot give general anesthetics, and they also do not have physician support. And so this is a dire environment these individuals are working in. And so the second part, and sort of what I've written about in my book, is about this, about health system strengthening, how we need resources, how we need education, how we need processes to track what's going on to make sure that we're okay. So what's the research we need to improve perioperative outcomes then? I think we've got to focus on leveraging data to strengthen our health systems. And the problem we have at the moment is that we don't routinely collect data, and because of that we cannot aggregate the data. And then on top of that, we don't have the granularity needed to understand why patients are dying. So for example, in ASOS2, had a great idea. What we'll do is, we know mothers die from hemorrhage, so we're going to have a small case report form, and when a mother dies in ASOS2, we will do almost like a confidential inquiry. So you think it's easy to deal with hemorrhage, but when these cases started to come in, there are so many factors which are contributing to that mother's death. Right from when they're at home, into the hospital, infections, they were so complicated. In fact, there's not a strong signal that this is where we should be focusing our intervention. So we need to focus on trying to understand more why patients are dying. So if we look at leveraging data, I think we've been really good and successful in APOG is that we've always had limited data points. We've had no nice to have data points. We've got better and better. I think in ASOS2, there's only one data point we didn't use in the main publication. And the idea is that we provide a low burden on the sites, and we have a high volume of sites. And so the clinician investigators across Africa have been fantastic, and literally with over 300 hospitals contributing data to these studies. And I think we've created a culture of quality. The data in APOG is excellent. So how do we deal with failure to routinely capture data? I think we've been good because we've been pragmatic and we've had a limited data set. If we look here, this is the history of the APOG projects. For the main outcome of mortality, we've got better over time. And you can see now in the most recent study, ACIOS, that we had missing mortality data in 0.4% of the patients. This is high quality data delivered in a low resource environment with almost zero funding. We also need a bridge to integrate data in health care systems, and a digital reading app I still think is a real possibility, a way to go. I know Beacon City in the audience is working on this, and I know HALE's working on this, in ways that we can navigate some of our limitations in IT. If we can't aggregate data, it means we got problems in tracking site-specific projects and their success. So you might have a local quality improvement project, and similarly tracking how we're doing on the continent. And so to do that, you need standard data sets. So you need a standard data set that's collecting data at a site, allows the sites to track their own performance and what they're interested in, and aggregate the data that we can check how we're doing in a continent. And also, if we have studies, it makes subsequent studies easier. But we do have a standard data set. As a group in AppOrg, we've already developed this data set, and if you scan that QR code, it'll take you to the paper. What we have to do now is we have to get this data set into our clinical practice. And then finally, even with this baseline data, there's this granularity which we do need. So if we want to understand why mothers die of hemorrhage, we actually need to interrogate the cases where the mothers died. And so we need high-quality, case-specific data for poor outcomes if we want to improve outcomes in Africa. So for me, obstetric hemorrhage is a classic example. I think what we need is an African continental national audit project. So just like they have NAPS in the UK, and I think if you've been tracking this cardiac arrest in theatre NAPS 7, extremely interesting, extremely useful data has come out of NAPS, and that's what we need to improve outcomes for problems in Africa. So I'm proposing that our next target should be going for a continental audit project. Why could it work? Well, I think there are three reasons. I think one, we've proven that we're good at pragmatic limited data sets. We have a minimum data set that we can use as a baseline. And if we had these granular outcomes for the specific cases, I think then we would understand what's needed to improve surgical care. So this must be our goal, is to provide this pragmatic, robust baseline data which is supplemented with high-quality, granular case-specific data, like a NAP, like a confidential inquiry. So I'm going to suggest that we should look towards a continental audit project where we ask, why do patients die after surgery in Africa? Thank you.
Prof, do we have time for questions, or we'll do it afterwards? Thank you for a very insightful talk, Prof. As usual, you've left us with something to think about. It is my pleasure to now announce the next speaker, Professor Angela Enright. She already came bearing gifts to some of us this morning in the plenary. Very much appreciated. Professor Angela is a former president of the WFSA and a former president of the Canadian Anesthesiologists Society, an emeritus professor of the anesthesiology at the University of British Columbia, and an executive section editor of Global Health of Analgesia and Anesthesia. Thank you, Prof.
Thank you very much for that introduction. And again, it's a great pleasure to be here at the All Africa Congress in Johannesburg. And my job today, this morning anyway, is to talk about publishing in academic global health. And just my disclosures, as you've been told, I'm the executive section editor of Global Health for Anesthesia and Analgesia, and I've been supported to this meeting by the journal. So my objectives this morning are to discuss what makes a manuscript interesting to a journal editor, what are some of the common problems in submitted manuscripts, and some steps to help in increasing the acceptability of a submitted manuscript for publication. So I'm going to start by outlining what the challenge is, and I'm going to show you some figures from Anesthesia and Analgesia and also from the Canadian Journal of Anesthesia. These are figures given to me by the editors-in-chief of these journals and allowing me to use them. And on this graph here, just look at the blue line because that's really the only one we're concerned with. And what that is the number of manuscripts submitted every quarter to the editor-in-chief. And you can see that over the course of a year, we're looking at about 2,000 manuscripts. That's a lot of manuscripts coming across the desk of the editor-in-chief. This will surprise you perhaps, maybe not someone like Bruce who publishes regularly, but the big areas in pink those are the rejection rates. So all those articles that fit in that pink area do not get accepted for publication. The yellow ones are those that are still under review, and the green are those that are published. And you can see over the course of 2023 to the first quarter of this year in 2024 that the number of manuscripts accepted for publication has gone down at ANA from around 20% to now around 6%. This does vary a little bit, but that shows you what you're up against when you submit your manuscript, which is one of those 2,000 coming in the year, that it is really difficult to get published in a big name journal. Here are the figures from the Canadian Journal, which is a little bit different in that it's a smaller journal, and obviously it's the Journal of the Canadian Anesthesiologists Society, which tends to lead to a little preference for publication within Canada. And so their submissions are just under 1,000 a year, thereabouts, and the rejection rate in the Canadian Journal is about 70%. So once again, it gives you an idea of just how difficult it is to get your manuscript in print. This is a picture of the World Bank classification of countries according to income. And you can see in the mauve color, that's the light purple color, those are the lower middle income countries. The deep purple are the low income countries. And most of those are on this continent, with some in Asia and some in the Pacific. And I just want to show you then where our publications come from in ANA in relationship to those countries that fall into those low and middle income countries. For ANA, we get a lot of submissions from Asia, usually Japan and China. You can see a significant number, as you might expect, from North America. Similar, slightly smaller number from Europe, probably because Europe has many anesthesia journals, and so they're not sending as many to North American Journal. Africa, you can see we're on the map, and that may look very low to you, but that's a big increase from what it was 10 years ago when Africa was hardly on the map at all. Oceania is the Australia, New Zealand, Pacific Islands, and of course they have their own journals as well. And South America, not very much in this journal because language is a big problem for anesthesiologists and researchers who tend to be very much more unilingually Spanish or Portuguese speaking. Looking at the Canadian Journal, which will give you a slightly different picture because they do it by country. And on the submitted manuscripts, you can see that Canada has obviously the majority, the USA perhaps being second. And if you look for countries that were on that World Bank low and middle income country group, there's China, there's India, and there's Brazil. And China has a lot of submissions, but India, a smaller number, and Brazil, hardly at all. But if you look on the other of the accepted manuscripts, you see, obviously we accept a larger number of the Canadian manuscripts and the USA, but China has diminished from that large yellow on the one side to that small amount of yellow on the accepted side. India, similarly so, and Brazil is still there. So you can see that the challenges of getting your manuscript into publication, and most journals would look like this, no matter which country they're in or whatever. It's a big challenge. So how do you improve your chances of getting published? Well, it all begins before you start the project, and I think probably what Bruce has been saying is learning to avoid the pitfalls before you start really helps you to get things right. And so it's really good to seek advice from an experienced mentor. We were talking about mentorship earlier this morning. And if you're going to do research that you want to have published, seek advice from the best mentor you have in your area. And look at the studies that you think are good, that are published, and see what's good about them. And if you want to know what should be included in your manuscript, go to the Equator Network. It lists a checklist for every type of research to show you what you must put in it in order to have it published. And I'll have a QR code at the end that will give you a lot of links to the material that I'm talking about now, and that will be helpful to you in looking for information about this subject. And focus on important outcomes. That's really important, as you'll see, because you need to ask yourself, am I doing something that's worthwhile? Is it new? Is it novel? Is it going to make a difference? Is it going to be significant? And it may not be new in the scheme of the world things, but it may be new and different for your particular context, in which case it is important. Very important to think about these. And then you have to think about, how well can I do this? What's the quality? Am I going to meet the qualitative needs? And that's before you start. So what is a good research question? Well, you've heard lots from Bruce about what good research questions are, but this is something that might guide you a little bit. It's called the FINER criteria: feasible, interesting, novel, ethical, and relevant. So feasible, especially if you're a junior researcher and you don't have a lot of resources, you need to know that you can actually bring this research to conclusion, that you have enough participants, that you have the money, that you have the technical expertise, and that you have the time to do it. Is it an interesting question? Does it make you interested in finding the answer to the question you're asking? And how about your peers? Would they be interested in this as well? Does it extend the knowledge that exists already, or does it refute something that's been held as gospel for a long time, and maybe you can prove that this gospel is not correct? It's really important that you will be able to pass ethical review at your review board or ethics committee, because if you can't do that, that's probably going to end up with a refusal to either to do the project or to be published. And finally, how relevant is it to healthcare, to what you do every day, or to health policy? Or is it something that research can be built upon? Now, when the manuscript arrives at the editor's desk, these are the things that we look at. Does this research meet the standards required, both scientifically, ethically, and statistically? If it doesn't meet those standards, your likelihood of being published is very slim. In the writing, does it meet our language and literary standards? And for people whose first language is not English, that's quite difficult. We got lots of papers from native English speakers that are not well written. So if you can get some help, if you're not a primary English speaker and you're submitting to an English-speaking journal, get a native English speaker to help you to go over this, to make sure that you write well. And finally, we have an audience of readers, and we have to make sure that what's published is of interest to the readers and that they will like it. So when a paper comes in, obviously we look at the title and the authors. We put it through a series of tests, for instance, the one I listed there, looking for plagiarism, and if the red flags come up there, then that's not a good thing. Make sure that the abstract really is reflective of the content of the journal. Many people seem to write the abstract first and then the manuscript second. It's really important to write the manuscript first, then the abstract. Remember that readers often read the abstract, and depending on how well that's done, whether they'll go on and actually read the whole article. So your abstract is really important. So when the paper or the manuscript comes to us, we have a choice of saying, this is never going to make it, and rejecting it. That does happen, not in a huge percentage of cases. Or we can accept it straight off, and that is even rarer. It's very rare for an article to come in and be accepted right off the bat. Mostly we send it out to review, and this is where we're looking for good peer reviewers who will be content experts. Remember, the editor can't be an expert on everything, so we rely on our reviewers to give us the feedback which will help us make the decision about the manuscript. And when we get their reviews back, they will often recommend either accept or reject, but most often they will say revise or reconsider or accept with revision. And then you, as the author or the contributing author, will get a letter from us saying, please, we like your thing, but please revise and reconsider based on all of the reviews that we've got. And so it's really important, and I can't emphasize this enough, how important it is for you as an author to read the comments from the reviewers and from the editor and think about them. Do you agree? Do you disagree? Do you see the reason why they're suggesting a change here or a change there? Discuss it with your fellow authors. Often I find that the author who's written to us just does it all himself and doesn't contact the other authors. But you need to do this as a team. If you're accepting responsibility for the paper, you need to have input into it as it is revised. And respond to the comments. You don't have to agree with them. You can say, I see the point, but we think our point is important and we'd like to keep it this way. That's perfectly acceptable. It's also acceptable to make changes, but be careful when you're making changes that you don't introduce other problems. That's not uncommon. So a new problem comes up. So take it seriously. It's constructive criticism. It's meant to be constructive, illustrating why you might want to make certain changes to make your manuscript more readable, more understandable, make some corrections perhaps in the statistics. So improving your chances then, you've got a nice paper. You've got to choose the right journal. If you're just starting off and this is your first case report, you're not going to send it to the Lancet or the New England Journal. But there are journals, for instance, ANA Practice, where case reports are the thing that they thrive on. So if you're somebody who does a lot of regional anesthesia, maybe you're going to think about, maybe I should send it to a regional anesthesia specialty journal rather than a general one. So choose the right journal. Avoid predatory journals. These are the people who are constantly popping up on your email. Please send us your work. We love your work. We love you to come for us. They are just a scam. They don't have a decent peer review. They want to charge you a lot of money to publish. And if you don't know who they are or how to identify them, we've got something on that QR code that will help you, but go to your librarian. They will help you identify these and avoid them. Pay attention to detail. I can't overstate how important it is to state the aims of the study clearly, and then whether or not you've achieved those aims. It's really important to include your approval ethics And if you're doing a trial, you must register your trial before you recruit patients. If you don't do that, that's just a no-no. So these are small things, but they're really, really, really important. Finally, proofread your manuscript before you send it in to pick up corrections. There are lots of methodologies to do that, to proofread and grammar read it, and as I say, look for a native English speaker. So in summary then, start off on the right foot by planning the project properly, make sure you meet the standards and get help with writing if you need that. Each journal has specific requirements which are stated in the instructions for authors. It's worthwhile reading those and making sure that you follow those because they sometimes want things laid out slightly differently, like the references, for example. And listen to what the reviewers tell you. They're trying to be helpful. They're trying to help get you published. So listen to what they say, and whatever happens, keep on writing. You've got to keep on doing it because you will make it, you will get there. And there's the QR code. If you just take a picture of that, that will give you lots of information on where you can find references and so on for helping you bring your manuscript to life. Thanks very much.
Thank you so much, Angela. It's my pleasure now to introduce Zipra Gatuya. She's also a well-known member of our research fraternity in Africa. I'm going to read out everything while you walk up to the stage. Thanks, Zipra. So she's internationally renowned pediatric anesthesiologist with more than 20 years of experience both in the public and private sector, currently venturing into public health, focusing on access to safe, affordable and high-quality anesthesia and surgery, especially for children. She's a member of the Global Medical Advisory Board for Smile Train and the Secretary of the Global Initiative for Children's Surgery. She's passionate about education and safety in pediatric anesthesia and was instrumental in the setting up and running of the Pediatric Anesthesia Fellowship at the University of Nairobi, the first of its kind in East and Central Africa. She's currently involved in the pediatric anesthesia training in Africa, which is running pediatric anesthesia fellowships in Uganda, Zambia, and Nigeria, while also aiming to improve pediatric anesthesia skills for all anesthesia providers for children in Africa. She's currently working as a pediatric anesthesiologist at the Nairobi Hospital in Kenya. Thanks, Zipra.
Thank you so much for that splendid introduction. Unfortunately, today I'm doing none of those pediatric anesthesia talks, and I suppose this is what happens when you're shifting gear from clinical practice to global surgery. So we are going to talk about our short-term surgical missions. Are we getting best value in LMIC? And I must just start by saying I serve on the Global Medical Advisory Board for Smile Train, which does not support short-term medical missions as a way of conflict of interest, but to also say that I have previously worked with two groups that do short medical missions. One is Children's Surgery International, based out of the US, and Operation Smile. So I have a feel from both sides. So we are going to talk about some definitions, look at the history, and look at the impact, look at some ethics considerations, and do a pro-con debate, and then what is the way forward. Because I think at the end of the day, that is always very, very important. So when we talk about short-term medical missions, they are limited time, surgical interventions. Some visiting teams come from anything from 1 day to 8 weeks. They typically aim to provide surgical care to underserved populations, bridging the gap between surgical care and medical resources in LMICs mainly. And some definitions say that this model lacks sustainable value, but we shall look at that. So what is value? When you talk about are we getting value, how do you define value from a global surgery or clinical practice perspective? So we must look at the appropriateness, the effectiveness, the safety, efficiency, opportunity costs, and consider the patient's needs. How is the system responsive? What are the processes? So when you consider value, there are so many aspects that you need to take into consideration. I'll say briefly about team compositions. You may have people from the same institution going to a different institution, or you may have a collection of individuals from different institutions affiliated by friendship, setting organization, their faith, their geography, their origin. For example, you have Ethiopians living in the US organizing a surgical mission to where they came from, something like that. So the question is, considering the foregoing discussion, what value do these short-term surgical missions deliver? Can there be a way of improving the value to LMICs if it's lacking? And what can be done to improve the value for these visits for the visitors? And what can be done to address the source of problem if we think that they are not delivering value? So value must be to the visiting team and to the visited team. So historically, most of these missions were vertical, visiting team coming to the receiving team. And they would probably bring everybody on the team and bring all the supplies and all the equipment and have a post-visit itinerary, which would normally in Africa include a safari, a vacation, and usually arranged in the same. So what did the local teams do? They'll probably have an advertisement for the patients to come, provide the space for operation, provide interpreter services, and receive the visitors and bid them goodbye. In other words, in between there, they had nothing to do with it. So in the historical setup, the visitors would screen the patient, prepare the schedule, and sometimes they would come into the OR and scrub the theater, making you look like you've been working in this very dirty space, and pre-op their own patients, and you know the works, recover their patients, and take care of the patients and discharge them. So, but the reality is there are a lot of charitable organizations that are coming to do these short-term medical missions, with the US sending more than 400. The amount of money being used is very, very enormous, and many of these missions occur annually. And Africa receives the greatest number of these missions. The reality also is that people have realized there's a problem and they're trying to standardize the guidelines so that people, so like this article about guidelines for short-term missions. And it can also be very elaborate. This is a schedule from the Operations Smile website, and they have a schedule of what they're doing at every time and what the activity type is going to be. Very, very elaborate. So what is the impact? And how do you measure impact? So these are things that have a lot of discussion around them. Do you use surgical volume? Do you use outcomes? Do you use capacity builds? Do you use relationship developed? So you really need to determine what is your impact measure. The impact can be positive or negative. And when you look at the positive impact, is the actual provision of the surgery, if you can call that. You can call scale expansion, you can call infrastructure. And I would like to say that my being a pediatric anesthetist has its roots in one of these short-term medical missions, and how some people who had come on a mission discovered that maybe I have interest, and the rest is history. But negative impact is, what is the sustainability? Are they creating a dependency culture? Is there a disruption of the local health systems? And you can go on and on. There's also the economic impact. Are we reducing the healthcare cost? What is the opportunity cost of these things, and what capacity building efforts are there? So you can have a lot of this discussion about what you're doing with this. So ethics of care. Care prioritization. How do we choose the patients who are going to be on the list? Are people paying so that their patients can be put on the list? Is the cost of care practical, so that when this team leaves, are we able to continue with that care? What is the process of consent taking? Or is it people are told, oh, we have this visiting team, and if you want to be operated, just sign without anybody explaining to you, and we just take that consent? What is the scope of practice? Do we have people who are coming to do these surgeries, and then they do things that are out of their scope of practice without declaring? For example, you come to this country and you find a very interesting case. You've only probably done one in your country, and there's nobody who can do it here. You say, I can do it, without disclosing that you've actually just done one, and the rest is from theory. So those kind of things. So pro and con debates can go on and on. Is it a good thing? Is it a bad thing? And we have a lot of papers published on this. The con mainly is this voluntourism. People who come, it's just that they want to go on tourism or vacations after that. And then when you look at the travel service for Good Samaritans, what do these terms mean and imply? Of the money that is spent on these trips, you say that it's so much. A couple of these trips could fund a clinic with 2 or 3 local doctors and nurses for a whole year. So which is a better use of money? When you think about that cost, about 50% of the budget goes back to the sending community, because they will buy their air tickets from their own people. And many other things. They will buy the supplies they are coming to use from their country and come with it. And then there's also the cost to the recipients. So when the visitors come, because you feel, especially in Africa, we like to treat our guests well. I'm sure you're feeling that vibe here. So we want to put them in expensive hotels. We hire for them expensive cars to bring them to the hospital and back. We entertain them and those kind of things. And again, now these students passing off as consultants and experts, nobody knows. And a lot of research data mining, I'm sure we have issues about that, and unreported medical errors. So you can talk about them. Cultural adaptability, when people come. You see, sometimes when you come and scrub the theater, you may not think much about it. You just want to work in a clean space. But that says very a culturally inappropriate thing, that you don't think that what we do is appropriate. So you have no regard for the local system, for what is happening. And then the expert white savior mentality may mean that some of the patients who can continue getting care, if you come regularly, will say, I will stay with my issue. until the visitors come because we think that they do better care than the local team. So you end up undermining the local team in a way. For most of these missions, they want to take on the simple cases because then they have less complications and morbidities and mortalities. But maybe that is not what the local team needs help with. So if you do all the simple cases and you've taken our theater for a whole week, then our long-term cases are left. So then it has been shown that more complicated procedures may have a higher complication rate than where these teams come from. The follow-up, diagnosis, follow-up, unregulated and evaluated, and that perception that the patients are receiving better care from the visiting team. But on the other hand, the approach to this, look, they say sometimes those simple cases have a large backlog. So if you come and do a hernia camp and we had a hernia backlog for 6 months, maybe you may address that. So you can say that sometimes those missions can come and help with the backlog. And some other times in places where there's no care, you say some care is better than no care at all. And it gives you an opportunity for the host community to learn some skills if you incorporate them. But if you come and only interact with them when you arrive and then interact with them when you're leaving, when they are throwing for you the farewell party, then that doesn't happen. And there are many opportunities, relationships, again, how people relate with each other. There have been multiple, and I've given you my example, of relationships that have come up out of these missions. And exposure to different cultures, and there also gives you an advantage to advocate for some of the conditions. So when the visiting come and they have been dealing, for example, with cleft, then many people, even governments, because they like to come and host the visitors, it may be a way of doing advocacy. So what is the way forward in this thing? We appreciate that the short-term surgical missions are a big deal, yeah? We appreciate that they are doing some good, and in some instances, they are doing some things that are not so good. How do we merge all these things to define a way for going forward? And one of the things is that there needs to be a regulatory framework to ensure ethical, culturally appropriate, and accountable interventions. And this cannot be done from one side of the divide. It has to be by teams working together. Sometimes written MOUs and open discussions about expectations for both teams, both the people who are receiving and the people who are coming, is important, with no hidden undercuts. If you're coming to bring your students with you, you need to declare that these are students. And if the visiting team, the local team also have students, then you need to be equitable in sharing the opportunity for both sets of students in this. And then there needs to be, from all this money that is raised, to provide the local partners with funding commensurate with the resources used. So sometimes you may have brought things, but there are some things that you bought in country, and sometimes the local team ends up spending a lot of money. So even though it is free, then they need to be compensated for that, if that is what you need to. And then shared responsibility for sustainability and capacity building. And we need to realize when it's time to move on. And I think this is a greatest point to focus on. So if you come to the same facility over and over again and you're building capacity like you should be doing, you need to realize when you have built enough capacity to move on, so that you don't keep coming and now the people there feel like your worth is not necessary. So in conclusion, I'd like to pose some questions. How can the 7.5 billion USD that is used for these missions be used to strengthen the host surgical systems while still giving value to the people providing the donations and those coming for the missions? I don't have an answer for that, but I think it is a discussion that we need to have. Because if some of this money is used to strengthen our local health systems, then it may be more impactful in the long run for these groups. They are more effective when combined with longer-term strategies to improve the local healthcare infrastructure. The same thing, how do we strengthen the local capacity? And the aid of short-term surgical missions is not in sight. So, but they can have more value for all those involved. So what we need to discover is that how can we add that value? So, again, to the first slide. Are we getting value from these short-term medical missions or surgical missions in LMICs? And my answer to that would be there is some value, but we could have even more value if we work together and have a way of setting priorities that is concerned with those, both the visiting teams and the local teams. And not only look for the cases that have high photo moments, and I think cleft is one of those because that is how they'll raise a lot of their money with the before and after picture, but also have things that the local team is keen to move forward in this, and then have a way of the people who are bringing the money finding innovative ways of making sure that they have the same impact as the before and after picture, but they have more outlook on this other side. Thank you very much.
Thank you so much, Dr. Zipporah. We'll take questions at the end. So our next speaker is Professor Wayne Morris. Professor Morris is a practicing anesthesiologist and clinical associate professor in Christchurch, New Zealand. He is the immediate past president of the WFSA. He served as a chair on the education committee from 2012 to 2016 and director of programs from 2016 to 2020. He's lectured and taught over 60 countries worldwide. He has a co-developer of the EPM program and has been closely involved in the delivery of other educational programs such as SAFE and primary trauma care. He has published articles on a range of global anesthesia-related topics, including workforce, international standards, patient safety, and pain management and education. So today he will be talking to us about leadership and advocacy for our global specialty. Thank you so much, Prof.
Thank you very much for that kind introduction, and thank you also to the organisers for not only inviting me to speak at this meeting, but also for putting together an amazing program. It's wonderful to be back in Africa. It feels like a while since I was here, and my wife and I just had the privilege of a couple of weeks or 10 days in Botswana, and then a couple of days in Victoria Falls. So the photo on the left was taken in Moremi Game Reserve. But after Zippy's talk, I'm feeling a bit anxious that this might be seen as volunteerism. In 2008, there was a very important article published entitled Surgery and Global Health, A View from Beyond the OR. And in that article, the authors, Paul Farmer and Jim Kim, the former president of the World Bank, described surgery as the neglected stepchild of global health. A friend of mine from Boston, Craig McLean, said that if surgery is the neglected stepchild, then anesthesia is his invisible friend. In global health, anesthesiology just didn't really have much of a look in, but things did start to change around 2015. And I am interested that the title of this session is Global Surgery Intervention Strategies. I think we always need to reinforce that we are talking about anesthesia, and that is important when we are advocating to people in governments and people at WHO level. So during this talk, I'm going to quickly look at the global reality. I'm going to quickly talk about WFSA, the World Federation, then look at how WFSA is leading our specialty, and then how WFSA is advocating on behalf of all of us and our patients. I am the immediate past president of WFSA, so I'm not on the board anymore. Daniela Filipescu is here as the official representative of WFSA. I am officially a has-been. So what is the global reality? And I'm going to go over some points that you are very familiar with, but I think one of the problems that we have as doctors is that we do complicate our messaging. We need to keep things very simple, especially when talking to non-anesthesiologists. There's a really important concept, universal health coverage, and this keeps on coming up at WHO level. And it's the idea that all people should have access to the health services they need without risk of financial hardship. And it fits with this idea that health is a fundamental human right. And it's really important, I think, to keep on coming back to this idea that anesthesia is part of universal health care. And this is a figure that you will be very familiar with. 5 billion out of 7 billion people do not have access to safe anesthesia and surgical care when needed. And that comes from the Lance Commission on Global Surgery, which was published in 2015. The world's population is now 8 billion people, and that proportion has probably got worse. There's another really important basic point that we need to keep on making to the decision makers, and that is that there is a large burden of surgical disease. When we have been at WHO meetings, some of the decision makers there are just gobsmacked when we tell them that 4 times as many people die as a result of surgical conditions and trauma as the number of people dying from HIV, AIDS, tuberculosis, and malaria. And there's another really basic point that we need to keep on making, that we have a global anesthesia workforce crisis. This map was taken from the Global Anesthesia Workforce Survey, which was done in 2015 and 2016 and published in 2017. There has been an update to the survey, which was published in ANA at the beginning of this year. But this map, I think, very clearly shows the massive disparities worldwide when it comes to the anesthesia workforce. The scale at the top shows the number of anesthesiologists per 100,000 population. So red is less than 1, and the darker green is more than 20. And you can see that Sub-Saharan Africa and parts of Asia have very low densities of anesthesia providers. Following the publication of the Lance Commission report on global surgery, we were making some progress. So in 2015, the World Health Assembly, which is the main decision-making body of the World Health Organization, passed Resolution WHA 68.15, which was entitled Strengthening Emergency and Essential Surgical Care and Anesthesia as a Component of Universal Health Coverage. And that was a big deal. It was the first time that anesthesia had been specifically mentioned at that WHO level. and it was unanimously agreed by member states. But then, of course, COVID-19 happened, and it has really put progress back a long way because resources were diverted away from anaesthesia and surgical care towards treatment of or management of the pandemic. And we are still in this post-COVID hangover phase where we've got massive wait lists of patients who need operations or who have died without having the operations they needed. So we are still in a very difficult post-COVID space when we think about anaesthesia and surgical care. Just going to quickly go over the World Federation of Societies of Anaesthesiologists and what we are as an organisation. The title is important. It's your WFSA. I really want to encourage you to think of yourself as being part of this amazing global organisation. It's not this UN, WHO type organisation sitting up there. WFSA is its member societies, and we are as strong or as weak as our member societies. We have 140 member societies around the world, and we represent anaesthesiologists, 500,000 anaesthesiologists in 150 countries worldwide. That's pretty incredible. The reason for the difference in numbers is that some societies represent anaesthesiologists in more than one country. The Pacific Society would be an example of that because that society represents anaesthesiologists in about 8 countries around the Pacific region. And it is quite a unique organisation. There is no equivalent surgical organisation. And in fact, I think we've not only done a great job in anaesthesia and advocating for anaesthesia and critical care and pain medicine, but we've also done a great job in advocating for surgical care in general on behalf of our surgical colleagues. It's a unique global alliance, as I said, and we're a strong voice for anaesthesiologists everywhere. And we've got to be very mindful that as a global organisation, we're not just advocating for anaesthesiologists in Africa, but we are also taking into account the views of anaesthesiologists in other parts of the world, with different levels of resourcing. We have an official liaison role with WHO, which means that we can speak on behalf of anaesthesia colleagues around the world at official WHO meetings. And the slide there shows our basic structure. We have a board which is small, 8 members or 7 members now, which provides the governance oversight, a council with representatives from all around the world, 11 committees, and then a very small secretariat, mainly based in London. A couple are in Spain. Please take the time to visit the WFSA stand because we've got a good number of our secretariat at the stand at this meeting. This was a pamphlet that was sent out to member societies. It was last year, I think, and it just outlines the value of your federation. That word again, your. Our vision is universal access to safe anaesthesia, and our mission is to unite and empower anaesthesiologists around the world to improve patient care. They're very, very simple statements, and I hope that they resonate with you as anaesthesiologists and non-physician providers as well. So how is WFSA leading our specialty? We thought about what was important about our organisation, and it really falls under three headings: advocacy, education, and collaboration, working together. In 2023, at the beginning of the year, we met in London as a board, and we thought it's time for us to review our strategies, our strategic priorities in this post-COVID world. And this photo shows the board at the time. David Cheng's in the back from China, Mauricio Vasco from Colombia, Walid Habre from Switzerland, Adrian Galb, the president before me from the US, Daniela Filipescu, who's at this meeting, the current president, Then we have Amelia Gualch from Spain, myself, and Carolina Haylock-Law from Honduras. Unfortunately, nobody there from Africa, but we do have good African representation on our council. And this is the 5 strategic priorities that we came up with. We sent these out to our societies and received generally favourable feedback. So I'm just going to quickly go through them. First one is to champion the vital role of anaesthesiologists in global and planetary health. Strengthen member societies and enhance professional networks. Advance anaesthesiologist leadership within healthcare. It is so important that we are developing the leadership of our specialty. Work with member societies to ensure a well-trained and resilient workforce and improve safety and quality in anaesthesiology. All of these things we need to do by working with our member societies. And again, I hope these priorities resonate with you as anaesthesiologists. If they don't, then please let us know. If you think there should be something else there, we need to be responsive to that. Just for completeness, I'll put up a photo of the current board, and we've got Daniela there, the president. Carolina from Honduras is the president-elect. We've got Dr. Bala from India, the secretary. Walid from Switzerland, the treasurer. Pedro Ibarra, director of partnerships from Colombia. Faye Evans, known to many of you, who is the Director of Programs, and Luis Falcao from Brazil, who is Director of Memberships. So a pretty diverse board with lots of reach to different parts of the world. Now here are just a few of our activities that have been important from a leadership point of view. That workforce mapping that we did in 2015, 2016, and also published again this year has been pure gold when it comes to advocacy. We need that sort of information when talking to the key decision makers. We've also published the international standards with the World Health Organization. Again, very important to have that stuff in writing that we can use with governments to reinforce the importance of anesthesia care and standards. There's educational programs that will be known to many of you. There are short courses such as SAFE and their fellowships, publications and online resources such as Anesthesia Tutorial of the Week, and then meetings like this one and the World Congress. So how is WFSA advocating for our specialty? This is one of my favourite quotes. If you're not at the table, you're on the menu. And that comes from a guy who is a Republican senator called Michael Enzi in the United States. I was just thinking about this morning. It's not, you not only have to be at the table, you also need to bring something to the table. You can't just highlight all the problems. You need to be thinking about solutions to take to the table. So as I said before, we have this official liaison role with WHO. So we are our profession's global voice. If we don't speak on behalf of anesthesiologists and other anesthesia providers, nobody else is going to do it for us. We are officially a non-state actor. And as I said before, I think we've done a pretty good job at not only advocating for anesthesia, but critical care, pain management, but just surgical care in general. And here are some examples. I'm not going to go through all of these, but we've actually done really well recently at being at all the key WHO meetings. So that's not only the World Health Assembly and the board meetings, but all the WHO regional meetings, such as the African regional meeting of WHO. We've made multiple statements on the role of anesthesiologists, the workforce crisis, our role during the COVID-19 pandemic, and our role in the management of treating non-communicable diseases. We're involved in the development of medication safety guidelines. And something that we just started recently was an annual theme. So in 2023, our annual advocacy theme was anesthesia and cancer care. And it was very useful for us as an organisation to have a focus when we were talking at WHO and with other decision makers about the role that anaesthesia provides in cancer care, because it is not well understood. This year, thinking about resilience of the workforce, our annual theme is workforce wellbeing, and we've had a number of webinars and other events related to that theme. I went to the World Health Assembly last year and got to meet Dr. Tedros and got the obligatory photo. It was very nice to meet him briefly, and because I think he has been a real supporter of anaesthesia and surgical care. WFSA also spoke on behalf of, in support of two resolutions. One was a more integrated approach to emergency, critical and operative care, and the other one was increasing oxygen availability in low resource environments. Simple messaging works best. And I can't stress this enough, because as doctors, as healthcare providers, I think we always overcomplicate our messaging. We like complex arguments, that's the way we think. But you can never go too simple with some of these decision makers. So the messaging that worked really well, we found, was that you can't have universal health coverage without safe surgery. You can't have safe surgery without safe anaesthesia. So really simple messaging. We need to remind decision makers about the unmet burden of surgical disease and trauma. And I think it is important to also remind them that that burden has probably got worse because of diversion of resources during the COVID-19 pandemic. And I know I'm talking about the WHO and I'm talking about governments, but these are the conversations, these are the messages that you also need to be giving to your hospital authorities, also your own governments. And anesthesiologists play multiple essential roles in healthcare delivery, including critical care, and we need to keep on reminding people what our roles are. Again, you know, we're that neglected friend of, or the invisible friend of the neglected stepchild of global health. And we need to just keep on telling people the roles that we do. So here are the key points. Remember that the World Federation is your global professional membership organisation. WFSA is only as strong as its member societies. We are a specialty that is under pressure. There's a large burden of disease, not helped by the COVID-19 pandemic, and we have a workforce which is very vulnerable, and there are massive disparities worldwide. WFSA unites and empowers our global specialty, and we advocate strongly for anaesthesiologists and patients everywhere, and we have to keep on remembering that patients are at the centre of all of these leadership and advocacy efforts. You'll probably see this slide a few times at this meeting. Please start thinking about the next World Congress, which is going to be an easier part of the world to get to than Singapore. It is happening in April 2026 in Marrakesh, Morocco. And I don't have a slide for it, but the next All-African meeting is going to be in Tanzania in 2027. And that will be another amazing meeting. Again, thank you very much, and hopefully there will be some time for discussion later. Thank you.
Thank you so much, Wayne, and that perspective on what the World Federation is doing for us. It's now my privilege to actually welcome a surgical colleague to this meeting. Simukai Machawira is based at Pari Renyatwa Hospital in Harare, Zimbabwe. And there he heads the cardiothoracic unit at the hospital, which is the only unit that caters for Zimbabwe. He has a keen interest in both cardiac and thoracic disciplines. And in June 2023, he led the unit in the resumption of open heart surgery after a 5-year hiatus. Simokaya is going to talk to us on safe surgery in cardiothoracic surgery, where to with no resources. Thanks.
Good morning, ladies and gentlemen, and thank you very much for the invitation to present at this meeting. My topic is going to be adjusted slightly, safe cardiothoracic surgery, where to in low resource settings. So I work at Parenyatwa Hospital, a government hospital in Zimbabwe, and I will just go over the history of cardiac surgery, just to give an example of how difficult it is to work in difficult situations, but you can still find a way of working. I have no conflict of interest and I have nothing to declare. So that's the layout of my presentation. I'll just have an introduction, a history of open heart surgery in Zimbabwe, and then an overview of open heart surgery in Africa, and the constraints that we face in delivery of open heart surgery in Zimbabwe, and the opportunities that we have, and the recommendations on the way forward. So Zimbabwe is a developing country. It's just, for those who don't know, we're just north of South Africa. We have a population of about 17 million, and over 40% of this population is under 20 years. Predominantly our diseases, cardiac diseases, we have rheumatic heart disease as the leading disease. Obviously, congenital heart surgery, congenital heart disease is the same, being roughly 1% worldwide. And of note is that 70% of these congenital heart diseases can be cured by surgery. Also of note is that worldwide non-communicable diseases are now constituting about 40% of the mortality. And this is predominantly in low middle income countries. So Zimbabwe has undergone a significant political, economic, and social transformation over the past 25 years, which has resulted in disruption of our services. It's important for us to note that we need to give a patient good surgical care, and true access to good surgical care relies on timeliness, capacity, safety, affordability, and accessibility. So of note is in 1953, the first open heart surgery case was done in Zimbabwe. It was a patient with pulmonary stenosis who had open valvotomy by surface cooling. Subsequent to that, it was philanthropic missions that were coming, mainly represented by Loma Linda. And then Loma Linda, the team decided in 1988 to come and set up a base in Harare at Parenyatwa Hospital. They trained a local team, and they left the local team competent. And in earnest, local open heart surgery commenced in 1989 at Parenyatwa Hospital. Between 1995 and 2003, the locally assembled team was able to carry out about over 400 cases. And then in 2003, the program collapsed. This coincided with the land reform in Zimbabwe, which then relegated Zimbabwe to a pariah state, and a lot of funders withdrew from the country. Fortunately, in 2016, Medtronic, the company donated a heart-lung machine, and we were able to resume open heart surgery in 2016. We resumed open heart surgery in connection with the University of Konkuk, which is a South Korean university that came and led us in the resumption of cardiac surgery. And then between 2018 and between 2016 and 2018, we were able to carry out surgery, about 80 patients. And unfortunately, again, due to economic circumstances, the program collapsed in October 2018. So those are the patients that we managed to do. We are roughly doing about 25 to 30 patients in a year. And it would be folly for us to look at Zimbabwe alone and neglect Africa, where the situation in Zimbabwe reflects what is happening in the greater part of the continent. So for the greater majority of the population, open heart surgery remains a pipe dream. So if we look at the centers in states, we have one open heart surgery center for 120,000 people, whereas in Africa it's one per 33 million people. So that's how dire the situation is. North Africa is an exception, so we will divide Africa into North Africa and Sub-Saharan Africa. North Africa, along with the Middle East, have formed a regional alliance, and they perform the surgeries much more than in Sub-Saharan Africa. And in Sub-Saharan Africa, there are about 26 countries that offer open heart surgery, but few of them perform it regularly. An example being Zimbabwe. Fortunately, there are more countries that are coming on board. If we look around us, there's Namibia, there's Botswana, Mozambique, and Zambia that have now started offering open heart surgery. And just to put things into proper perspective, Africa performs about, Sub-Saharan Africa performs about 1/600 of what is performed in the States. So in the States, they do 1,222 patients per million. In Sub-Saharan Africa, excluding South Africa, it's 2 per million surgeries for the population. And the main reasons are lack of government support, financial constraints, and inadequate manpower and expertise. So the important thing I think we need to do is to make cardiac surgery a priority to our governments so that they can give us the requisite support. So that map shows the distribution of cardiothoracic surgeons in Africa, and the sad thing is, if we look at the most populous countries in Africa, 3 of the most populous countries have negligible cardiac surgery. I shall not name them, but 3 of the most populous countries in Africa have a negligible population of surgeons. And anyway, so the major constraints which I'm going to look at with particular reference to Zimbabwe are the infrastructure, equipment and consumables, human resources, remuneration, whether it's monetary and non-monetary, and also the implication of our policies. So I'll start with economic and political issues, which are mainly draw on the policies around the country. So Zimbabwe, after the land reform, had a lot of negative political sentiment by major Western powers, and as a result, we were isolated and frozen out of major financial and political institutions. So just transacting with other countries became extremely difficult. You had to go through second parties to be able to transact. And obviously, this was triggered by the unresolved land issue. So sanctions were imposed, and then the government went on to prioritize the areas of specialties. And I think most disciplines will realize in surgery that the disciplines that suffer the most in difficult economies is cardiothoracic surgery and orthopedics, because we use a lot of implements which are sourced out of the country. So this led to devaluation of our currency and the unavailability of foreign currency. And most of these consumables that we use are sourced out of the country. And as a result, we abandoned open heart surgery in 2003. Parenyatwa remains the only hospital in Zimbabwe that offers open heart surgery, both in government and in private. And this is the biggest referral hospital in the country, and as such, we are competing with other specialties at the hospital for resources. And usually we are at the bottom of this list because we require quite a bit of the budget to be able to do that. We also need high capital investment for the machinery and up-to-date equipment. So of note is we don't have a cardiac catheterization laboratory. There's only one in private, but we don't have one in government. The bypass machine we are using at the moment is a donated one. We are working on getting a new one. And we don't have intra-aortic balloon pumps. We don't have ECMO. And we also have this difficulty of securing consumables. So as a result, it limits the surgery that we can do because we do not have some sort of backup if we run into problems. Ideally, we should have an independent cardiothoracic unit, but we fall under a general ICU where we are allocated one bed a week. So usually we aim to do one patient a week. And I've already spoken about that. So if we look at our health professionals, anesthetics is a fairly large department at our hospital. It's got quite a good complement. Of all the anesthetists that we have, there's one that is cardiac trained. He was trained in Italy. We partnered with Mission Bambini and they took him in for training. We've got a fairly good population of cardiothoracic surgeons. So at Parenyatwa, we have 3 cardiothoracic surgeons working there, and there are 2 that are totally in private. So it's about 1 per 3 million, 1 cardiothoracic per 3 million in our country. And the cardiologists, we've got 2 recently qualified adult cardiologists, 1 pediatric cardiologist. The nurses, we've got a fairly good number of nurses, but if we're looking at our nurses, especially with the advent of COVID-19, you realize that if you look at the United Kingdom, we are 3rd after India and Nigeria in the recruitment of nurses by the United Kingdom, and most of these are specialized nurses. And unfortunately, we have 1 perfusionist. We had to entice her from retirement. So she's helping run the pump. We're in the process of getting 3 to get training. And the other departments are fairly well managed. So if we look at open heart surgery locally in Zimbabwe, the cost of doing a patient is $4,000 to $12,000, which for most patients, it's a catastrophic expenditure. They usually have to pay out of the pocket. Less than 10% of our population is on medical insurance. And fortunately, we have an organization, the National Oil and Infrastructure Company of Zimbabwe, that came on board and donated 350,000, and this enabled us to be able to operate on the majority of our needy patients. Otherwise, this would have remained a pipe dream. The Abuja Declaration states that 15% of the budget should go towards health. Unfortunately for us, we only got 11% last year. The government has been trying. We must be cognizant of that. In 2017, they gave us a budget of $3.5 million, which was mainly towards refurbishing and establishing a good unit. Unfortunately, there was a change of government then, and things did not work out as well, and our money was converted to local currency, and it lost value, and it never got to do anything. I also would like to look at the opportunities that we have, despite all these challenges that we've faced, we've had some opportunities that we managed to secure. The government gave us a grant last year, and in June 22nd, we resumed open heart surgery. And this has allowed us to do team building. So this we resumed with a locally assembled team. And we've been going on since then. And we still continue to pursue government for sustained support so that there is continued development of the program. We also engaged the private sector, and I'm happy again to say the National Oil and Infrastructure Company has granted us another $230,000 US for cardiac surgery. And we still continue with our engagements with the Mission Bambini and South Korea, where we send some of our colleagues to go on attachment to the units and train as, in the relevant fields. We are exploring opportunities with Tanzania and other local or Southern African Development Community countries and Egypt, where we are looking at sending people for perfusion training. And since we recommenced in June last year, our aim was to do one patient every week. We are now on patient 32. Obviously, we face the challenges with consumables, supply of consumables, and sometimes patients just are scared of surgery. We've done majority of the cases that we've done are mitral valve replacements. And next week, from Monday, we're looking at holding a local camp where we aim to do at least 10 patients. So we are trying to do 2 patients per day, just to keep our staff motivated and to show that this can possibly be done with a positive attitude. And our recommendations on the way forward, we will continue to engage with government to prioritize capital injection and sustained support. We will also continue to engage with government and other sectors to give incentives to staff so that we can retain as much staff as possible. And fortunately, we have managed to get an independent account. So now whatever money we get, we are now directing towards an independent account in open heart surgery, where we hope it will become a revolving fund. And we are still looking at establishing an independent cardiothoracic unit with at least 5 beds, ICU and high care. And we continue to encourage our local industry to support the program. And we'll continue partnerships with established centers so that we can get knowledge transfer. And we hope to keep the knowledge flowing. And that's our team with Mission Bambini colleagues who had come in 2018. And we would like to keep the blood in our patients flowing like the mighty Zambezi is illustrated there, flowing over the Vic Falls with all that beautiful scene. And I thank you. This is the end of my talk.
Thank you so much, Dr. Machavira. And I think this is a very good platform for those kinds of talks and collaborations with other specialities and other places. Last but not least, we have our last talk for the session. It is Dr. Zane Farina from Grace Hospital in Pietermaritzburg, KwaZulu-Natal, South Africa. I can tell that he's very modest because he hasn't said anything on his bio, so I had to Google him. He has over 20 years of experience in anesthesia. He is the clinical head of department at the hospital. I'm sure he's trained a whole lot of people because he's got extensive experience in training doctors in public health care, theatre planning, and assessment of obstetric anesthesia outcomes. And I think that is why he's here today to talk to us about the National Surgical Obstetrics Anesthesia Planning, yes, for safe surgery in South Africa. Thanks.
Good, thank you very much. Thank you for that kind introduction. One of my first hospital experiences, by the way, was attending Pararunyatua Hospital in about 1982, shortly after it had been renamed for a rib fracture from rugby. So well done on getting that place going very nicely. So I want to thank the organisers for the opportunity to share my thoughts on NSOAP for global surgery. I don't really have any relevant disclosures, or financial disclosures for this talk. My job, in other words, what I really have to do, is in the academic health sector, and I convene the South African Society of Anaesthetists Public Sector Business Unit. That means I'm fielding issues related to clinical care and the end results of bad care in the periphery day in and day out. And this makes me a global health and a global surgery believer, so I do have a definite bias in that I think we can make this work. So what is an NSOAP? An NSOAP is a National Surgical Obstetric and Anaesthetic Plan. It comes out, as you've heard already, from the World Health Assembly Resolution 68.15, where it was recognized that strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage was required. The goals, which were published by the Lancet Commission, authored by Mira, really what we've got to do is make sure that we've got access to timely essential surgery, an adequate specialist surgical workforce density, the ability to monitor the service and to ensure that there is adequate surgical volume. And then one target, a monitoring target, was set, which was perioperative mortality ratio, and then to avoid impoverishment and catastrophic expenditure by 2030 for the majority of the population. And targets were set, some to be met by 2020, some to be met by 2030. And frankly, we're not doing as well as we should. The original 5-component framework has had an additional 6th component added, which is governance. And governance is important because it shows that what you're doing, you're spending your money well. I'm sure that's some of the reasons for the success of the cardiothoracic surgery in Zimbabwe, is that you can show the governments that the money they give you actually turns into something effective for them. This complex slide can be unpacked on another day, but essentially it shows that you've got the pillars of what makes up a surgical service coming together into a national surgical obstetric and anaesthetic plan, which then has to feed into the national health strategic plans that everything is integrated. So what are the key elements that you need to see in an NSOAP? Well, the starting point is going to be assessment and planning. You've got to assess, the country has to assess its own surgical obstetric and anaesthetic capacities, including all the elements of infrastructure, workforce, equipment, service delivery, finance, government structures, and information management. Based on this assessment, countries should develop a national plan to address gaps and strengthen their services. This then comes one of the first bits that I think South Africa is struggling with, the integration into their current health services. Every country has a health system already, and part of the complexity for South Africa is its 2-tier health service with a large private sector coping with the health needs of the insured population and an overburdened public sector struggling for resources. Once you've made your plan, and only then can you start really talking to research allocation and funding, a successful NSOAP must provide guidance on the optimal allocation of resources that are available in the country, financial, human, and material, that are needed to improve service delivery in surgery, obstetrics, and anesthesia. Probably at this stage, by the way, please, I'm being a little bit global when I'm mentioning the word surgery, as we heard earlier on. You've got to take it in a bigger context with all the little ENT and ophthalmology and maxillofacial work and so on that is just as important, and I am referring to them as well. Once you know what you've got to do, you've really got only 3 options. Are you going to expand the amount of resources that are available, which really ends up translating into increased taxation? Are you going to find efficiency gains to redistribute resources to your NSOAP? And preferably, you've got to find those in your own budget, because, of course, as soon as you talk to somebody else and say, let's take out of the HIV program, you're going to hit a stone wall. And then that's the taking resources from other sectors, which are really very unpopular with those sectors. Many of those sectors have a stronger political voice than we do. Once you have your money, probably before it, because we should be concentrating on it now, you've got to look at training and education. A critical component of any NSOP is to enhance the training and education of healthcare providers in the surgical, obstetric, and anaesthetic field. And you've got to have an adequate and well-trained workforce to meet the population needs. South African academic centres are all under strain, reducing our training capacity. And I think while we talk about wellness, we've got to remember that a less skilled workforce is a stressed workforce, and a stressed workforce is less productive. Monitoring and evaluation is very important, and Hala has been at the forefront of that, and Bruce has mentioned elements of it in his talk. Currently, our data is poor. Private sector data is abundant, but it is restricted and controlled by the private hospital groups and the insurers, and it's poorly focused on quality and process improvement. Our state data is disjointed and unreliable, and in its current format, it cannot be used to make effective health decisions. We also need to look at equity and access. A successful NSOP prioritises equity in healthcare access, aiming to reduce disparities in surgical, obstetric, and anaesthetic services, particularly for the vulnerable and underserved populations of the country. And then we just put all of them together and just look at them on one slide. And we start considering, well, who actually has got an NSOP in place? So one of the first to be published was Senegal in 2015. And then Ethiopia in 2021 published it under Surgery Saving Lives. Zambia in 2017. We should be going on a little bit faster. There we go. Tanzania in 2018. And then Nigeria in 2019, along with Rwanda. Let my slides catch up with me. After Rwanda, there was then Pakistan in 2021, and congratulations to them for publishing a report during COVID, as did Ecuador, because we did see a definite hiatus in progress because of COVID and the redirection of resources. But Namibia produced something in 2023. And of course, in that, you've got what my talk is about, why no South Africa. We certainly had a lot of interested people, and a drive was originally led by Martin Smith, an important surgeon from Wits. And I think a lot of people will remember this advert and will have attended this. Surgery and anesthesia as an indispensable part. The program had all the correct elements with broad representation from surgery, anesthesia, and obstetrics. There was definitely a lot of energy in the room, and a lot of good work was accomplished. Task teams were set up, and I think if we dissected through all the work that was done, the elements of an NSOP were there. But the COVID got in the way. A formal MAC was not appointed. In fact, many members who should have been on that MAC then came on to go on to the COVID advisory MAC group, which did very well. The MAC is by a ministerial advisory committee, directly advises, acts as experts, directly advising the minister. Now, while we're trying to look at what went wrong and why we didn't manage to get a program together, I think it's been quite useful for me to examine this failure in light of Kotter's 8-step change management module. And for Kotter, the starting point is to create an urgency. Do you get people to understand that you have a need? And the wrangling over NHI that we currently have certainly demonstrates the government understands the current problem that we have. They know we have to do something. They know there's a problem. And from a surgery perspective, we've got a lot of backlog lists that have been created to catch up with the surgery that was missed during the COVID pandemic. And we've had waiting time initiative style attempts in many provinces to address this. Personally, I don't think that we've had a problem with create urgency. I doubt there's anybody in South Africa who doesn't realize that there's a need. The next step is to build a coalition. That's where you've got to get all the like-minded people together. And my question that I would ask there is, was everyone included? Because although we had good representation at those meetings, and certainly all of us were there as clinicians, I think we failed to bring the critical government role players on board. Preparing this talk, I communicated with many NSOP role players via email, telephone, and WhatsApp. Asked their opinion. What was going wrong? Why have we not succeeded? everyone felt that they'd done a good job, but there was some missing source, some missing ingredient that didn't make it work. And for me, I think it's been the political partners in the coalition. Once you have your coalition, you've got to form your vision. And the important questions is, was our vision aligned with others, and was our vision aligned amongst ourselves? I think we were pretty well aligned amongst ourselves, but it's amongst the others, the people who are perhaps not inside the coalition, that the vision was not as clear. And I'm hoping, and certainly from the talks that I've heard so far at this conference, that we're getting a lot of the vision made clearer. You've then got to enlist an army to put together, because your army are your soldiers, your group of champions, doers, and enablers who implement the above-mentioned plans and visions. Now, personally, I believe that an army does already exist. It's often not appreciated that the State Health Service currently employs more medical doctors than it ever has. South African health services are better staffed than they've ever been. We're also in the unusual situation where we've got unemployed doctors. There's no more funding to employ those doctors, and there are many doctors sitting at home. There are no funded posts to get to. However, this army that I allude to is untrained, inexperienced, largely consists of doctors that have sometimes even been trained outside our health service in different models, and we need to find a way to integrate them. And some of that then comes into the next step of the Carter's change model, which is enabling action. Now, certainly if you look at recent parliamentary questions to the Minister of Health, it is claimed that most of the surgical backlog of COVID is cleared. And Gauteng Health has dismisses attempts to discredit the successful elimination of historic surgical backlogs. And it would be interesting to hear from the audience members whether they think here in Gauteng that backlogs have managed to be addressed. There have been public-private partnerships, such as the one with Mediclinic, which across the country has seen many Department of Health surgeries conducted in underutilized private resources. But I think we've heard the problems that occur with that sort of action in the context of the voluntary missions, because do they leave any sustainable trace behind? A very important component is that you generate wins. The early generation of wins enables you to sustain interest and will. The early adopters will move on to the next best thing if you don't generate some wins for them to feel powerful about. The late adopters will never come on board your program unless they see the program as achieving something. So I think we did have some win. The advisory committees that were coming about because of COVID played an important, because of safe surgery, played an important role in COVID resource allocation. They've played an important role in getting the backlog slates cleared. But I don't see them as these being perceived as wins by the role players. So why are we struggling to have these wins seen as wins? And to me, it seems that we need a lobby group on our side, either created from amongst us or recruited from amongst the politicians. Now, once you've done this, and this has now moved beyond what we've achieved already in South Africa, you need to sustain acceleration. And certainly our acceleration in the formation of the group was disrupted by the COVID pandemic. But you've got to do something. Elon Musk says we've got to keep thrusting to keep going, hence the hot staging. And then you've also got to remember which direction you're going in, and perhaps he should become Space Y if he wants to get to Mars. The negativity around NHI needs to be turned around, and some of our assets as SASA as an organization we're going to have to move from trying to protect the functional private health system from being damaged to rather building up the state service and presenting it as a reliable alternative that can actually do the work. And that's going to take a lot of public-private partnership, because once you've got the sustained acceleration, you've got to institute lasting change. And the important thing about all lasting change is that it has to be preceded by changed thinking. Any other type of change where you haven't changed the thinking will only be temporary. So what are the key elements of the change in heart? You've got to do perception management. And unfortunately, we are still identified as being highly specialized, very expensive, and not particularly cost effective. And there's a few mantras that we've got to start spreading out. And I think if the same word is coming out from a lot of us, the word may be heard in provincial administration systems. How much does it cost to scale up surgical systems in low-income and middle-income countries? Desmond Jumbin co-addressed that with John Meara, and it's not that expensive. And then Salome Mswimi was quite influential in this, I think, as well, and Emmanuel Makasa. Investing in surgery, it is a good value proposition for South African leaders. And Bruce, just one more punt for your book, because I think that Bruce has really set it out very well in this book about how we can effectively change surgery in Africa and how it's much more expensive to not change it than it is to try and go forward and accept the things we need to do. Just a little word while I was reading around this. There may be some similarities. We may have an opportunity to work with, from the Indian model. Because India came up in this assessment of where NSOAPs were in 2017, and they said that health policy is generally set at state level. And the development of a single national level plan is both impractical and likely impossible for a country as large and reasonably complex as India. Now, India has 20 times the population that we do, 200 times the population that we do. So it is a different level of complexity. But on the other hand, in South Africa, we have got this mantra that is often quoted when you're trying to do change: health is a provincial competence. In other words, what KwaZulu-Natal does is not the same as what Western Cape does, not the same as what Gauteng has. And perhaps we should be developing provincial plans, or even contextually perhaps on a smaller level, health district level. Smaller plans, by the way, will be somewhat different to a big national plan, because the smaller plan is going to be a lot about ensuring that the simple surgery is done at the local district hospital, and that the referral pathways and the mechanisms of getting patients to the higher referral centers are optimized. So we may have to have a different plan if we go down to those small levels. So what's the way forward? Well, pleased to announce that I'm not as though I'm the first person who's saying it, that the Ministerial Advisory Committee for Safe Surgery has been reconstituted. Salome Mswimi is chairing it. And hopefully that group will work together to find a way forward, dig out all those original plans that were made, look at what is actionable and look at what will take us forward, rebrand and rebuild and reform that coalition. So I'm actually looking quite forward to it. I think we've got a chance. I think we've made some mistakes in the past, and I think that we can do this in South Africa. Thanks very much for the opportunity.
Right, thanks, Zain. We've got 2 minutes for questions and comments. There's one at the back here.
And I saved them for you so that you could ask them to Bruce.
First here, Sylvia, and then your chance. Just speak nicely into the mic because it's recorded.
Thank you very much. My name is Mpokuli Subisia. I'm from the Cardiac Institute in Tanzania, and I want to laud to the presentations that were made. I'd like to comment on the last presenter. That is true, Tanzania published the National Surgical Obstetric Anesthesia Plan 2018, but it was the first country in the world to cost it. So it's not just a question of writing what is required in a plan, it's necessary to know how much it will cost for implementation purposes. I'd like to comment on the wonderful presentation from Zimbabwe on the cardiac surgery. I think one of the problems that we face in Africa is silo existent. All of us are facing the same challenges, but when it comes to addressing solutions, each one stands on their own. Each one wants to reinvent their own wheel, while there are some that are running and are very operational. The question of manpower, you correctly said, perfusionists can come to Tanzania. We offer an MSc program at the Muhimbili University of Health and Allied Sciences. All they need is to apply, and the rest becomes history. Every 2 years, you could be having enough manpower to fit your need. We also, in the College of Anesthesiologists for East Central and Southern Africa, together with the College of Surgeons for East Central and Southern Africa, we are mulling into offering fellowships that will offer surgical, for surgery for surgical colleagues and anesthesia at a later date. These will be trained in the or abiding by the fellowship model in the centers where these are offered, and this will cut across the board from the little human beings to the geriatrics. The cardiac center in Tanzania is the largest in Africa. I just want to bring this to the attention of everybody. We have 150 beds dedicated to cardiac surgery with 16 ICU beds, 8 for adults and 8 for pediatrics and that age group. We have 2 teams, one that deals with pediatrics and the other one that deals with adults. So the learning environment in this climate is quite a wash. Health commodities is a serious challenge. We learned this when Africa was faced with the shortage of vaccines for COVID, and the solution was to make our own vaccines, and South Africa led the way. Isn't it time for us to start thinking of partnering with those major producers to set camp in Africa? And that is going to address the need, but also the price, together with pharmaceutical industries. There's no way we can compete with the West. I just met a gentleman from Germany last week who told me that the price of medications in Europe is a pittance compared to the price that are being quoted for the needs that we raise in Africa. This we need to sit down as a bloc and address it. If each one of us is going to approach those guys, there's no way we're going to make it with the meager resources of the 11% of the government budget in funding for the open heart surgery. Last but not least, SADC has a pool procurement policy in place, and the Medical Supplies Department of Tanzania was mandated the responsibility of procuring for the whole of SADC region. Whether that is being employed now or not, I can't tell. There is great wisdom in economies of scale. The more you buy, the cheaper the commodities. We could buy together, and then each one of us takes as they need. Thank you very much.